off of our Zoom platform. So we're hopeful that there are still some of you with us, and we will proceed from here. So with that, I'll turn it back over to Joe. Joe?
Thank you, and again, apologies. We'll keep pushing forward. We started because of both the healthcare system not functioning as individuals and our citizens wanted, and because of the price pressures in both the public and private sector recognized in 2009. Since 2011, we have evolved a bundled payment strategy that initially was a concept that included prospective global bundled payments, in which we would put a lump sum and pay for an episode prospectively. This met with a significant amount of consistent and strong negative reaction from providers and other stakeholders because of the lack of integration and infrastructure present to be able to support a prospective payment system. Following extensive provider engagement and stakeholder input, we helped shape the current model, which is a retrospective payment model. And it now includes also, along with the retrospective bundles, an integrated patient-centered medical home to coordinate those episodes going forward. So if I could have the next slide. And this was in the context of a number of system transformation efforts we had underway in addition to the payment system. We had workforce efforts going forward that included the development of new nurse practitioner schools and physician assistants. We had a transparency initiative with an all-payer claims database. We obviously had electronic health records coming online. With the passage of the Affordable Care Act, as previously mentioned, we found a private mechanism to utilize the Medicaid expansion dollars. And obviously this is all on top of a base of trying to improve the underlying health conditions and decrease the risk burden of our population as a whole. Next slide. This is a pictograph, if you will, of the components of our model. If I could have the next slide. It was wrapped around the patient themselves. And this is not going to work as I thought it would. Basically, what you're not going to have is a graphic that shows all payers coming together to wrap around a patient-centered medical home with episodes as it goes out as an individual needs specialty care. I think we have a function of the Zoom system here. If I could go to the next slide. A central component of our effort was to have it be multi-payer and coordinated across the system. We got our public payers, Medicaid, our private payers, Arkansas Blue Cross, Blue Shield, QualChoice, Centene. To the extent Medicare put options on the table that were consistent with, we participated in the Comprehensive Primary Care Initiative and other recommended activities. And then along the bottom, we encouraged and solicited support of self-insured companies. The two largest plans in the state are the state and public school employees. The largest private sector plan was Walmart Corporation. And then we also incorporated a Health Scope, which is a multi-payer employer-supported group, and the University of Arkansas system. All of these payers came together to achieve consistent incentives and standardized reporting and rules for the providers, to reinforce and support a change in practice patterns to apply to as many patients as possible, to provide coordination and consistency to give providers enough scale to justify investments in new infrastructure and operational models, and hopefully over time to give an opportunity to motivate patients to play a larger role in their health and healthcare by having information that's available to select higher quality, more efficient, better outcome producing providers. If I could have the next slide. Our episode strategy is to incorporate all care associated with the treatment for a specific medical condition. To have that condition be time-bound, to have a defined start and end point, to incorporate quality measures that are a requirement for any financial advantage, and to identify a lead principal accountable provider, or a PAP, assigned as the quarterback of the episode. Efforts, particularly by the Center for Medicaid Medicare Services, our episode strategy is mandatory. All providers with the treatment for that specific medical condition are required to participate. The episode is implemented by individual payers. So all payers may not implement all episodes, but if they implement the episode, they are consistent and mandatory in participation. This is intended to reduce the variation in, or the episode is intended to reduce the variation in cost and quality of care across providers for similar services, and to improve the quality and coordination for the patient, resulting in reduced inefficiencies across the healthcare system and ultimately a lowered cost of care. All of our episodes do incorporate upside and downside gain and risk sharing financially on the individual entity identified as the principal accountable provider. Next slide. From the provider perspective and the patient perspective, here's how it works. Patients seek care and select providers as they do today at the recommendation of their providers or others. Providers provide the episode-related costs. This includes both principal accountable provider and any other provider associated with that episode. Those providers submit the claims as they do today. The payers reimburse for all the services covered as they do today. Post hoc, if I could have the next slide. The payers calculate incentive payments based upon, first, a review of claims from the performance period to identify the principal accountable provider. They then calculate the average cost for all services inside of that episode for each PAP and compare those averages costs to predetermined levels of commendable and acceptable or not acceptable. And then based on results, providers will either have a shared savings. For example, the cost below a commendable level that met quality targets would share in the savings to the system. They would pay part of the excess cost if they are a high-cost provider, based upon an average of cost above the acceptable level. Or if they're an average provider, they would see no change in their payment other than that they received for their delivery of services. If I could have the next slide. This episode-based approach had significant input from providers and patients alike. We had over 500 provider, patients, family members who participated in a series of stakeholder and development meetings. We had public work group meetings in 6 to 8 sites linked by video conferences across the state, and following conclusion of an episode development would have public town hall meetings to explain the outcomes and the results. There were literally for each episode probably 24 months of research, analyses, review, and also infrastructure development to launch this episode successfully. And then monthly, we had and still have now in our 6th year, a monthly meeting with the Arkansas Provider Associations, including the Hospital Association, the Medical Society, the Waiver Association, the Developmental Disabilities Association, and all of the participating payers to actually have a monthly update and triage session to see what's working and what needs to be refined. Going forward, next slide. This was in our case for change that we made to providers. Here are 4 of our initial episodes that were launched. On the upper left, a simple upper respiratory infection, the upper right, pregnancy, the lower left, attention deficit hyperactivity disorder in children, and the lower right, total hip replacements. Each of these bars for each of these conditions represents a principal accountable provider's average cost for a similar episode. And you can see what we demonstrated was high variation across the episodes. For upper respiratory infection, the highest average cost for a provider was $100. The lowest was less than $40. For pregnancy, it ranged from somewhere over $4,500 to around $3,000. For attention deficit disorder, some providers averaged over $8,000 to $10,000 a year, while others provided a year's worth of ADHD services for less than $300. And finally, for total hip replacements, wide ranges of variation for the hip replacement itself. These were somewhat narrowed in terms of eliminating comorbidities, providing a risk adjustment, and indeed, when we shared this information with the providers, their resistance to an episode-based payment melted because they saw the variation between their colleagues and who was getting paid, and the question turned to why is somebody else getting paid so much more, and where do I fall along the spectrum? If I could have the next slide. Following the description of the variation, we convened stakeholder groups and mapped patient journeys along the path so that we could identify opportunities for improvements in prenatal care, for example, in pregnancy to avoid complications, and opportunities in either delivery decisions or monitoring decisions around the time of delivery to avoid unnecessary C-sections and to achieve better health outcomes. Importantly, throughout the process, if I could have the next slide, the principal accountable providers are provided new tools to measure and improve their care. They were provided information about an overview of the quality across the entire episode, an overview of the cost effectiveness, how they themselves are doing relative to cost thresholds and relative to other providers, and an overview of utilization for their episodes of a principal accountable provider's average episode cost. Importantly, this information was not limited to those services provided by the quarterback or the principal accountable provider, but were for all services provided to that individual by all providers, so that the quarterback could actually have line of sight on what other providers were doing to their patients. If I could have the next slide. Examples of our Wave 1 episodes were not dissimilar to others that had been implemented subsequently. In our total hip and knee replacement, the triggering event was a surgical procedure of hip or knee replacement, and all related claims 30 days prior or 90 days after, and we assigned the principal accountable provider to that to be the orthopedic surgeon. Because the orthopedic surgeon had the greatest ability to change how care was delivered, they had the greatest financial incentive to deliver that care, and they had the greatest influence on the system to make change. For pregnancy, the triggering event was the delivery of a live-born, and pregnancy-related claims for the mother 40 weeks before and 60 days after delivery were included. Similarly, for ambulatory upper respiratory infection, the triggering event was a diagnosis with a 21-day window beginning with the initial diagnosis. Congestive heart failure, very similar to the readmission issues of those of CMS. And importantly, an effort to try to address chronic disease with attention deficit hyperactivity disorder. We wanted to look at a 12-month episode for the physician or licensed mental health provider that provided the greatest proportion of services that were related to that mental health condition. If I could go to the next slide. This is an example of how the episode payment system worked. And again, the graphics are not displayed because of the Zoom function, but we'll try to see if we can get these. If you can imagine the bar graphs all going down to the bottom, if you were commendable, if you were below commendable, you shared in the gains between the commendable and the gain sharing limit. We did set a gain sharing limit so that physicians or quarterbacks would not be able to cut corners below that we believed would be high quality, efficient care. If you were above the acceptable line, however, after payment, you owed money back to the payer. For Medicaid, this resulted in a 50-50 gain sharing or 50-50 risk sharing enterprise. If you were below commendable for gain sharing or above acceptable for risk sharing, the private payers set different gain sharing and risk sharing, and those are not publicly available, but they are consistent in directionality and concordant in terms of the quality metrics and the other requirements for individuals. If we could go to the next slide. These are the current participation in multi-payer episodes. You see across the different episodes, our first 5, we've joined those with colonoscopy, cholecystectomy, tonsillectomy. We added another mental health condition, oppositional defiance disorder, and are moving into the more advanced surgical procedures. Medicaid has operationalized all of these. You can see when Blue Cross or QualChoice have joined. If they join, they operationalize the indicator with the same performance metrics, the same time periods, the same principal accountable provider, so that we get multi-payer consistent input into the provider community. Next slide. Here's a rough example of the volume of our multi-payer episode over the course of the last years. You'll see the implementation of episodes as they sequentially became available, and you'll see the growth in proportion of care provided largely for specialty services under the upside-downside gain-sharing model in Arkansas. Next slide. With Walmart support through the first 3 years, the Arkansas Center for Health Improvement has published a statewide tracking report available on our website here, and we'll be glad to provide additional comments and follow-up communications if there are those from the webinar here. This represents the assimilation of the experience from both the public and private sector for each of the episodes and shows progress moving forward. If I could have the next slide. These highlights, just to pick out a few, reveal, for example, the upper respiratory infection episode, a 28% drop in unnecessary antibiotic prescribing for nonspecific upper respiratory infections over a 3-year period. For delivery, we've seen sustained improvements in perinatal screening rates, reduced C-section rates, and as presented at Academy Health, a 3 to 4% overall cost reduction in a controlled experiment compared to neighboring states. For tonsillectomy, we've seen pathology use down 48% for non-suspicious removal of tonsils for Medicaid, and we've seen a cost reduction for Arkansas Blue Cross Blue Shield of approximately 5%. We've seen reduced Medicaid congestive heart failure cost by 14%. And in terms of the gain and risk sharing, we're really not talking about huge sums of money. For Medicaid in 2015, they shared $519,000 in terms of gain sharing payments across their episodes and clawed back $257,000 in risk sharing for providers across the implemented episodes. So I can go to the next slide. We have had some challenges. Our attention deficit disorder episode was a little less clean than some of our procedure triggered episodes. This was a year-long episode algorithm that required some technical updates as the providers within that episode modified their practices. One of the challenges was we had multiple provider types. We had primary care providers, and we also had severe providers that served the severe and persistently mentally ill population that had somewhat different business models. So the implementation of the financial incentives may have been disproportionately applied. We did observe what we believe to be the potential for some coding subjectivity. Medicaid saw a substantial decrease in billing for the attention deficit hyperactivity disorder itself, with a simultaneous increase in billing for the oppositional defiant disorder, which at that point in time was not part of an episode, hence the subsequent implementation of the ODD episode. And finally, this really did require an intensive level of one-on-one outreach to over 400 providers to help inform and discuss alternatives for stimulant prescribing, which is contraindicated in conditions for oppositional defiant disorder, but which after the transition in coding, we continue to see prescription practices ongoing. So this is not to say that these episodes are without challenge and to offer some caution. I think if I can have the next slide, just to summarize the differences between our model and at least the BPCI model. Our model is mandatory. It assigns episode type specific principal accountable providers at the individual level usually. And it's based upon who has the most ability to influence treatment decisions, influence the cost, and improve the quality of care for the individual. The bundle payment for care improvement model, conversely, is voluntary, allows for variation in who the provider is that is signing up and who participates. As our observations, a majority of participants are hospitals or skilled nursing facilities. They have the option to assign individual physician champions, but lack the consistent kind of multi-payer reinforcement from multiple different channels coming into the provider community or the hospital system for change. If I could have the next slide. These episodes were all part of a broader initiative that had patients assigned to what was we call the patient-centered medical home, but this is really a more advanced population-based health management strategy of the state. If I could have the next slide. This medical home population strategy has been rolled out over the course of the last 5 years, originally with the Comprehensive Primary Care Initiative. Then in January of 14, the multi-payer patient-centered medical home started, and we now have, after 5 waves, 80% of the primary care providers in the state participating in a multi-payer population-based patient-centered medical home strategy, where each of the payers is required to put a minimum per member per month payment in that is at risk for continued accelerated changes in practice transformation, upon which they are promised, at least for Medicaid, a 50% share in the savings they make to the system, again, if appropriate quality metrics are achieved. The private payers have a floor of $5 per member per month at risk payment, but they set up the gain sharing arrangements through contract outside of the public eye, but in a consistent direction to reinforce similar change going forward. If I could have the next slide. Statewide, we have, as I mentioned, probably 80% of our primary care providers. These include both Medicare participating comprehensive primary care plus clinics, as well as the Medicaid and private sector clinics here. The next slide, through this population-based strategy, Medicaid has observed a 16% reduction in hospitalizations per beneficiary for 1,000 beneficiaries, and almost 5.5% reduction in emergency room visits just over the course of a 12-month period. This represents dramatic improvements, we believe, in the quality of care resulting from 24-hour live voice access, after-hours and next-day clinic appointments, requirements for electronic health record utilization and integration into the state's electronic health information system, as well as increased line of sight, candidly, by investments on care coordinators and patient managers inside of the clinic system themselves. If I could have the next slide. Medicaid has paid out, has recognized over $55 million in projected cost avoidance, and has paid out about $35 million in shared savings. This represents a significant contribution to the provider community. Providers have received from between $50,000 to some providers over $1 million in 1 year's worth of shared savings payments for gain sharing because of cost avoidance and improved efficiencies in the system. If I could have the next slide. Sorry, these represent the clinics that have had those savings and the amount that I just referred to there, between 35 and $1.5 million. Next and almost last slide, I think this is a real opportunity for improved transparency, both transparency within the system and in the future transparency external to the system for public consumption. It has been a heavy lift with billions of claims processed for reports to display quality, cost, utilization metrics. It does, with the paired approach of episodes and patient-centered medical homes, facilitate the integration of primary care and specialty support via these episodes. We now have principal accountable provider engagement occurring with our primary care providers prospectively for elective opportunities and then re-engagement post-episode for across all opportunities. We're having our primary care providers start to ask for the profiles of the specialists so that they can make better referral patterns. And new for 2017, that information on specialist referral source is being made to those primary care providers to optimize the experience for their patients, the efficiency of the system, and actually because of the reinforcing financial incentives that they have now having a quarterback responsibility on care beyond their clinic, but throughout the entire spectrum of care. Overall, this reporting transparency, we believe, will have more effective tools than have previously been available, and we continue to push forward on the transparency initiative with our all-payer claims database and opportunities to increase the public's visibility into how the healthcare system works. Finally, let me give you our website at www.achi.net. This is where you may find the complete state tracking report. And the next slide, as new information is available, if you want to follow us on social media, this is how we are pushing things out in real time and actually having dialogue and conversations with not only our policy community, but also our payer, provider, and increasingly our patient population itself. Thank you for your time today. Be glad and look forward to questions.
Joe, thank you so much for that informative presentation and also for soldiering through our technical difficulties. The results that you're showing from your efforts are truly impressive. We do have a couple questions. I think you made up some time here and appreciate that, so we'll go ahead and pose those. I do want to assure folks that are on the phone, the attendees, and we really appreciate that the large majority of you have kind of stayed with us through our technical problems. You missed nothing. We broke and have also, we'll put the entire presentation on the website afterwards. So when we lost contact with you, there was no presentation that was going on. It was resumed when we were able to reestablish the connection. So I just wanted to clarify that. We've had a couple questions on that. There's a question, Joe, you talked about your principal accountable provider and how you selected that for the particular bundles. I think there's maybe more of a granular question we have here. How did you determine that provider? Was it through claims data, or to talk a little bit more specificity about how that determination was made?
Sure. So through the process of development, the principles of who had the most control, who had the most financial risk, and who had the most influence to change the system was the guiding basis for selecting who the principal accountable provider was intended to be. So in the surgical procedures, it was fairly straightforward. It was the surgeon providing the procedure itself. For the readmission, it was the index hospital, which was congruent with other national models. I would say specific answer to the question, it would be the designated principal accountable provider who billed for the service provided. So frequently was the billing surgeon or the billing hospital, index hospital, or for example, in the upper respiratory infection, it was the first clinician who billed a URI diagnosis. They were responsible for everything that happened downstream from that.
Great, thank you. We do have a few more questions we'll come back to at the end. In the interest of time, I'm going to turn now to Andy Baskin, again, the National Medical Director for Aetna, who participated as a payer stakeholder at the table during Ohio State's innovation model design process. Andy will share his reactions to Joe's presentation and also share insights on the commercial payer perspective in multi-payer episode design. Andy, take it away.
Sure. Thank you, everybody. Hi. Not just the commercial payer perspective, but perhaps specifically a national payer's perspective, which has its own challenges. So certainly I've been labeled as a reactor here. I just want you to know that reactor does not equate to being contrary. And I'm actually just providing national color and national perspective. I've been in the weeds a lot on this in the very beginning as I was very much involved in the Ohio process, which we inherited a lot of what happened in Arkansas. I want to commend the work that happened in Arkansas. They were the first out of the gate with this process, always difficult. We've had an iterative process that monitors, modifies, and improves the initiative, which I think is fantastic. And just the power of the benchmarking data to the providers alone has tremendous appeal. However, as a national or multi-state payer, my concern becomes greatly is to how to scale this beyond Arkansas. In other words, it can work in Arkansas, but can the same model work outside of Arkansas, or the same process, more importantly, work outside of Arkansas, and at the same time allow the process to pay out locally? When we started out in Ohio, we were told, not told, but so much as this was presented to us as how things went in Arkansas, and the process was very much the same, except that it was repeated. So in the sense where we put providers and health plans together to try and develop these episodes and the rules around it and the processes, the decisions were allowed to be made locally. So therefore, it put into the process a lot of variability. And I guess I would question, for those of you who have to do this beyond one state, does that variability get you enough? Is there enough value in that? So when I'm talking about variability, I'm talking about just the episodes themselves. What does the episode include? What diagnosis codes? What CPT codes? What's excluded? Which members are excluded? These are differences that are important in implementing, but in my mind may not be so important in adding extra value, and may not be improving upon it. And it's unclear to me that local decision making is necessary and actually is very costly in the long run. Some of the things that we learned in this process is that I agree with the retrospective approach. Prospective is extremely difficult in terms of infrastructure, claim systems issues, which are very, very costly and very manual up until just recently when some software became available to do some of this work. Concerns about going from the simple bundles where we all probably started in hips and knees and then moved out of there. When you get into certain bundles like ADHD bundles, where the experience is that drug or medication costs may start to overwhelm the rest of the bundle and create a lot of the variability, it becomes an issue of whether those bundles should be divided into those with drug costs and those where drugs are not involved. In mixing them, we run into issues where providers may or may not choose to start medication to keep someone in the less costly bundle where there's no drug costs. So I know that Joe talked about some issues with coding issues. There's also issues potentially with low-risk patients getting into a bundle by easy diagnosing, as potentially was mentioned, as opposed to removing people from the bundle by not using the diagnosis because they may turn out to be costly. And I don't know what drove that, but certainly a concern when we see that kind of thing happening. The other thing that happens is that when you move outside of Arkansas, I noticed that Medicaid was obviously involved with all of the bundles, but that initially there was only one large payer, which is the Blues plan, and secondly, I saw a Qual Choice, which I was happy to see as a second payer for some of the bundles. When we started in Ohio, we started with 5 commercial payers who had significant market share, plus the Medicaid plans in Ohio. That's a level of complexity that actually makes this much more difficult because not only are there more payers that have to agree, but the market share of each payer becomes a smaller portion of the total market share. So I, as a national plan, Aetna may, in many practices, have a market share of only 5 or 10%. Others may be 10 or 15%, but nobody's huge. That makes it very difficult because of the differences that are still allowed between the providers and the payers in terms of how the money flows and how this gets implemented. So it creates a significant barrier for us. It also creates a situation where the denominators start to get small quickly as you have a more wide marketplace where there's multiple providers with portions of the market or smaller shares of the market. It became very quick in just a very common bundle, which would be a hip or knee replacement, that after you get past the first dozen or so provider groups within the state of Ohio, you start to get ends that are annual ends that may only be 30 procedures for a particular payer-provider combination, and there then the statistics work against you, and that creates some difficulties. I want to make sure I just get into part. The mandatory involvement, I think, is actually very strong when it can be agreed upon, and I realize there were challenges in Arkansas, but I commend you for being able to do that because, frankly, that does increase the end. It does reduce some of the complexities to have everyone participate. In Ohio, it was voluntary for health plans and voluntary for providers, at least in the commercial world. I think it was not actually so voluntary in the Medicaid world. Which created some issues, at least from my plan. It created a situation where we would share data and acceptable and commendable levels, the same sort of thing, which is helpful for benchmarking to providers, but we actually chose not to contract for the bundled payments, and in other words, implement the dollars and cents of actually going through the program. So we contributed data, but not necessarily did the contracting for this because of many of the reasons I spoke to. One of the other things that I'm concerned about is placing financial risk on those who are capable of handling the risk. It's a little unclear to me, but when I look at potentially a mental health provider as being someone who's taking on risk for ADHD patients, and I see that wide range of dollars, so that there's significant dollars at risk for some of those providers, it becomes a great concern to me whether we're putting financial risk on those in our system who are probably, as providers, least likely able to handle it from a capability standpoint of view. Many of them don't even have electronic health records, let alone the capabilities of taking on risk. They're not necessarily highly reimbursed providers, so small amounts of risk can make a big difference there. And I actually wonder if some of the decrease in ADHD coding may represent a silent pushback from the provider, sort of a passive pushback that says, hey, I really don't want to be in this, so I'm not going to use that diagnosis. And I'd love to hear Joe's responses, whether he thinks that really happened or not. So those are the few of the things that color this from a national perspective that make it work really well in a given state, but very hard to duplicate in multiple states where a national payer would have to essentially do it a little bit differently everywhere creating a lot of extra complexity, variability, a lot of extra costs, and it's unclear whether the financial gain is there, especially seeing the total dollars here that were involved in financial risk and financial gain. So thank you for that.
And thank you, Andy. Any thought there, Joe, in response to the question that Andy just raised at the end?
Sure, and let me thank Andy for his comments, and there are few, if any, that I disagree with. Just for clarification, the providers, the principal accountable providers, and all other providers continued to get paid as they were before the episode went into place. So there was no capitated risk. There was just the opportunity for an additional payment if they were in the commendable range, or for a potential clawback with some ceiling limits if they were in the risk sharing. So I understand the concern there. I unequivocally think that we had provider transitions. We have some relatively large Medicaid concentrated mental health providers that anecdotally said it was less expensive for them to pay the penalty than it was to change their operating practices. So I do think you've got at least some savvy providers that delved into the technicalities of the episodes to figure out how they could minimize their exposure and continue without transitioning to a new paradigm.
Great, thank you for that. And we will go now to a couple questions that we've received. We have a couple questions that deal with what I'll call kind of the alternate payment model overlap question. So just generally, we're wondering, were there any payers or provider arrangements that had traditional risk deals in place that interfered with the episodic nature of the bundle? And how did you handle those overlap situations? I think that's a question for Joe.
Sure. So our environment has probably on the spectrum across the states a relatively low penetration level of full risk sharing at the procedure level. So while there may have been some of those in place, the majority were still under a fairly open fee-for-service model within each episode. I think if there were a risk-bearing opportunity, then each of the private payers, through their public agreement, would have organized the quality metrics, would have organized the definition of time frame, would have organized basically a full risk model for an episode is an extension of the upside-downside gain sharing that was put in place through our episode and would have been consistent with the model.
Great, thank you. Early on, you referenced that patient and families were involved in the design. We have a question, Joe. What did their contributions look like?
Sure. So it was important for us to have not only patients and families, but we needed to have academic and community providers. We needed to have large and small groups. One of the ones that was the most poignant is in our congestive heart failure readmission. The Heart Association actually found I'll say a young woman who she herself had congestive heart failure and her mother had died of congestive heart failure. So there was really, when some of the technical, relatively micro issues came up as potential, concerns on the medical community of why we should not do this, that having that consumer voice at the table to say, here was my experience and what went wrong, led frequently to knocking down some of those concerns and moving forward to find a solution for a value-based, outcome-oriented payment system.
Great, thanks, Joe. A question for Andy. From an Aetna's perspective, why is being at the table when there's a pursuit of alignment across multiple payers, why is that important to Aetna and for payers generally?
So, I mean, for just mostly, well, for many reasons, technical being one of them. I mean, one of the things is, as I mentioned, is complexity and variability with no obvious gain to be had, other than those can say that I was able to put my thumbprint on the process and on the bundles. Seems to me personally, not worth it. So the idea that we could all agree on what an episode looks like, what the timing is, and what the reports are going to look like, the quality metrics and all that makes total sense to me. I may have had a preference for one change to a bundle, one exclusion to bundle than others, but you need to lose that and realize that change doesn't provide enough added value to warrant the added expense and resources, time, energy, and camaraderie and collaboration that goes along with this. So frankly, I think that's extremely important, and it's also extremely important if you want the data to statistically mean anything. Not only the quality data, but any of the utilization data or the dollars numbers. To have that, you just need volume, and volume hides a lot of mistakes or a lot of more minor decisions, in my opinion.
And if I could just add, I think it's an important currency to use with the provider community to say we're going to have a consistent approach and consistent reporting. I think that bought a lot of goodwill and willing participation by the Medical Society and the Hospital Association to see this as a coordinated and consistently aligned effort, as opposed to what historically has happened with each payer having a slightly different reporting requirement.
Great. We're coming up here on the top of the hour. We do have a few questions that are in the queue that are very specific to the Arkansas program, and so we would encourage you to visit the website at www.achi.net to see if you can get answers to those questions here. We do want to again thank both of our presenters today, but also for the participants to hang in today on today's call. We do want to share with you just that we have an upcoming webinar schedule that in September we'll be doing a social services integration on effective financing strategies. In October, we'll also be having the path to transformation, moving an organization from volume to value. We've got a large research project that's coming now to market there, the output of which, and also in November on the essential elements of effective accountable care. So this is a cadence for future webinars. You can certainly sign up for invitations to our series. We give you that link here in our document. And we thank you again today. As a reminder that this presentation in its entirety will be, it has been recorded, will be posted to our website within 24 hours. And you'll be able to access them by going to www.hcttf.org. You will also receive a short survey via email in the next 24 hours that seeks your feedback on today's webinar. Our webinar series is really in its early stages, and we welcome your feedback on the operation as well as any potential future topics that you may find of interest. So with that, we'll end. Thank you very much for today, and once again, thanks so much to Joe and Andy for their participation. Have a good afternoon.